we're very excited about the results that have been recently assimilated on the use of Ibrutinib along with a antibody that targets a protein called ROR1. This protein is expressed on CLL cells, and we know that it's hardly expressed at all on normal tissue cells, including normal blood B cells. And it actually is a very intriguing study because we know that Ibrutinib does many things to inhibit the pathways, for example, in B-cell receptor signaling, and has a profound effect on the treatment of patients with CLL. And it's changed the landscape of how we approach patients with this disease. We clearly know that use of Ibrutinib inhibits not only B-cell receptor signaling, but also chemokine receptor signaling. And as a consequence, when patients first start therapy, there can be a huge increase in the lymphocyte count. And then over time, that lymphocyte comes down. More slowly for some patients than we would like, though. And we have to ask the question of why does it take so long for the leukemic cell counts to come down, at least in some patients? And why do some patients never normalize their lymphocyte count? We do know that Ibrutinib is very effective, but typically when we stop therapy, we take our foot off the brake and the disease can accelerate again, particularly in the early phases of treatment. So we have to ask the question of what other pathways may be active in the leukemic cell that keep it alive. That's very important. And ROR1 is a very interesting molecule because not only can it be used as a marker to distinguish CLL cells from normal B cells, but there's a functional consequence of ROR1. In other words, ROR1 is receiving signals from what we call the microenvironment in the lymph nodes. And one very important factor that we identified was the protein called Win5A, which is a factor. Interestingly enough, we find at very high levels in the plasma of patients with CLL. So it's not just confined to the microenvironment. So you can see the story where patients have their leukemic cells flushed into the blood. They may still get signaling through ROR1, even though the cells are not in the microenvironment. So what does the ROR1 signaling do? Well, it activates a number of pathways through ROR1. These are very important for inducing B-cell proliferation and survival. And so we know that the pathways, for example, of MAP kinase activation, which activate ERK1 and 2. We also know NF-kappa B is activated by ROR1 signaling. And another key important pathway that may be activated is a pathway called NRF2. So with the ability to block the signaling with the use of an antibody, we can turn off those signaling pathways. And so the question was whether if you use that type of approach in conjunction with Ibrutinib, would you have a 1-2 punch in being able to cut off one of the survival signaling pathways that may be accessible to leukemic cells that are in patients that are just treated with Ibrutinib. And so we've been following very closely the results of the study. That's a study that's been done at multiple institutions, and I'm looking forward to the presentation at the ASH abstract, and it's going to be one of the oral presentations. Now, they're treating patients with CLL in addition to treating patients with mantle cell lymphoma. And we know that mantle cell lymphoma cells, like CLL, have very high levels of expression of ROR1. And some of the same features that we've noted in CLL also apply to mantle cell lymphoma. In other words, the ROR1 as a protein is actually activating similar activation pathways and may be helpful for stimulating the survival and the growth of mantle cells. Ibrutinib is very active in mantle cell lymphoma as other BTK inhibitors. However, typically the responses are not as prolonged as we see in patients with CLL, and that is a problem because the complete responses are less in terms of the percent patients achieve complete response, and the duration of the response is shorter. So it's very interesting to actually use this 1-2 punch to also treat patients with mantle cell lymphoma. Now, there's some key things that are going to be presented that are quite exciting to me. Namely, in the case of mantle cell lymphoma, it's clear that although this is not a randomized study, it's an early study, the response rates for patients with mantle cell is much better than we would have expected. And the duration of response is much longer than would have been expected based on data from other clinical trials using ibrutinib or even the drug acalabrutinib. So it's very intriguing, particularly some of the patients who have adverse risk factors such as mutations in TP53, which we know is a bad player in terms of patients' ability to respond to chemotherapy. So the data with mantle cell lymphoma is actually showing very encouraging signs. It's easy to see how someone who may not respond very well, and you can improve the response level. In the case of CLL, ibrutinib does such a good job. We know that single agent ibrutinib, particularly for patients who've not had prior therapy, can result in prolonged progression-free survival, over 80%, even at 3 years. And I think that that's being borne out here. Namely, patients with CLL are doing well with the combination, but it's like, how do you improve upon 85%? Well, it seems that there might be a possibility. And really, an important subgroup of patients which was included is actually the patients with deletion 17p and mutated TP53. Typically, these patients can respond to ibrutinib fairly well. However, the responses are not as robust as patients who do not have this mutation. It is an adverse risk factor, and actually one that's associated with the development of resistance to ibrutinib down the road. Surprisingly, I believe now there are 10 patients that were treated, and the follow-up data is over 30 months. And the progression-free survival for that particular cohort is actually 100%. These patients are doing extremely well and appear to be doing better than the patients that do not have deletion 17p. And if you take it in context, patients with deletion 17p, typically with ibrutinib alone, would probably score in the 70% range, particularly if they've had prior therapy that's even worse. And so this included patients with prior therapy and patients who had not had prior therapy. What's exciting for me, and I love this, is that I never tell a patient that they have leukemia with bad risk genetic factors. I never do that because it puts the onus on the patient. I tell the patient that these genetic changes may represent challenges, and if we had improved therapies, we can improve the outcome. And many times we've seen that, particularly for some genetic lesions. We've seen the situation turn on its head, where having that genetic factor may be a good thing. I love that because, patients don't have to go home and say, my God, I have a terrible risk factor, I'm going to die earlier. No, we need better therapy because we should be able to turn these risk factors into something that may be actually improvement in terms of outcome for our patients if we had the better therapy. So we'll see how this bears out. There are some mechanisms that account for why patients with TP53 mutation may do better. And I think it's very exciting for us because we do have some data with regard to that, and we're working on some other studies. But it seems that when you have mutations in TP53, it makes the leukemia cell a bad player in terms of response to therapy. We know that these cells do not respond to chemotherapy well. They do not respond to radiation therapy. And it's because the major cop on the block, namely P53, that's able to recognize damage to the cell and say, hold the phone, we're going to stop cell division and I'll induce cell death if you don't get your act in order. That is gone. The TP53 mutation actually kind of absolves himself of that role, but then takes on other function. And these other functions can enhance genomic instability and the ability for the leukemic cells to progress and evolve into more resistant forms of the disease. Well, this has a cost, and we do feel that some of the pathways that are activated by ROR1 signaling are probably serving a necessary role to a part for these cases where you have mutations in TP53. And if you take that out from under the a CLL cell, then they may be more susceptible to undergoing spontaneous cell death. So we're looking at that mechanism.